Hi class, this is the chapter 15 lecture. However, before we get started on the content for chapter 15, there's something I want to go back in and discuss in chapter 14. So let me go ahead and share that slide that I need to clarify. Okay, so this is content from chapter 14. And I noticed when I went back and edited the chapter 14 lecture that I need to better explain the relationship between the chordae tendineae and the papillary muscles. The way that they work is the papillary muscles, when they contract and relax, they don't pull the valve open. They don't pull the AV valves open, which is really what I led you to believe in the chapter 14 recording. Instead, the way that they work is they're preventing the AV valve from backflowing. So they do work like heartstrings, like a parachute, in that they anchor the AV valve through the chordae tendineae down, but it's not the contraction of the papillary muscle that opens and closes the AV valve. What opens and closes the AV valve is the pressure of the blood. The way that it works is, think of it from being positioned in the ventricle. When the ventricle is full, and as it's filling up, that pressure pushes the AV valve back. So, and then the heartstrings, the chordae tendineae, are pulled tighter, which would engage the muscle. But the way that the interaction between the papillary muscles and the chordae tendineae is one just to prevent the valve from blowing open, which would lead to regurgitation through that AV valve. So anyhow, I thought it was necessary to better explain that for you. All right, let's get switched over now to chapter 15. All right, chapter 15 is on blood vessels. And this will complete our discussion of our cardiovascular physiology. We are going to discuss everything in the chapter, but we'll talk about the lymphatic system more when we do chapter 24, which is on the immune system. All right, so if we take all of our blood vessels, our cardiovascular system, and lay it out, we actually began earlier in the chapter 14 lecture in a similar view. This is what we'd have. We've got some new elements here, though. What we're discussing in chapter 15 is are the different blood vessels and how pressure moves through our cardiovascular system. So let's go ahead and begin at the heart. In this figure, they are separated out, since the left heart is what goes to systemic circulation and the right heart is what goes to the pulmonary circuit. So that's why it's showing it as two separate pumps, which is accurate. And then the connection between there would be the pulmonary circuit allowing the deoxygenated blood to exchange. So as we pump out of the left side of the heart, that left ventricle, blood is going to go through the aortic semiluminar valve, through the aorta, through the various arteries, arterioles, and finally down to the capillaries. The arterioles, so they end in, notice the ending here, IOLES. The arterioles are shown with a clamp on them. And the reason why is because these are the type of artery that have a thick muscle layer around them. And that allows the body under different influences to either constrict the muscle, which would collapse, reduce the diameter of the blood vessels, or relax the muscle, which would increase it. So the arterioles are capable of applying resistance in the form of decreasing the diameter or radius of the blood vessel. The reason why there's this red dotted line around the arteries is because arteries have an elastic component to them, which means they can stretch. And this is a good thing. They're right next door to the heart. So if the heart is pumping really hard or really fast, that's going to put more pressure through, or if we put more volume through the heart. So the stretching there of the arteries allows for the increase in pressure at times when we do have an increased pressure. That happens normally at many times during our day, such as if we exercise. Okay, so our arteries really work well at storing pressure. We can control several aspects of that. We'll continue to talk about that. So the arterioles feed into the capillaries, which are the exchange sites of our body, such that every single cell in our body has access to a nearby capillary. And then they feed into the venules, which then feed to the veins, back up to the vena cava, going into the right side of the heart, where they can go to the lungs to breathe out, get rid of that carbon dioxide and load in oxygen. So our veins, we've got a blue dotted line around here. They don't serve as a pressure reservoir. The arteries do that. What happens in the veins is the majority of our blood at any one time sits here. 2/3 of our blood volume is in the venous side. 1/3 of it exists in the arterial side on average under normal conditions. But our veins have the ability to push more blood through if we need to increase cardiac output, or to hold it back. So our veins really serve as a blood reservoir or fluid reservoir. The arteries serve as a pressure reservoir, where the veins serve as a fluid reservoir. So both of them have the ability, or certain vessels on both of those sides have the ability to stretch under the right conditions. All right. So depending upon what type of blood vessel we're talking about, there are different amounts of epithelial tissue itself. I mean, capillaries just have one layer of epithelial tissue, but there are also different amounts of smooth muscles around it, and different concentrations of fiber, or different amounts of fibrous connective tissue. So the aorta, right by the heart, right, it has quite a bit of all of that. It needs to have a lot of that fiber there so it doesn't blow open from the pressure of the heart. So we do see that the actual thickness of the wall of the different vessels is different. So from the very inside out, the inner layer is endothelial tissue. And again, capillaries have just one layer. And there are different materials that are secreted here. Paracrine factors are going to act nearby. So they're acting locally. We've learned about this word now. The endothelial layer, so it's important in producing some of those signals, but it also is important in helping the vessel to grow and just function properly. So we've got different amount of smooth muscle around our different blood vessels. And these are arranged in either circular or spiral layers, we'll see, and allowing the blood vessel to either constrict or dilate, to vasoconstrict or vasodilate. Keep in mind that muscle tone, which is that minimum amount of contraction needed to maintain our posture, this has an impact on our cardiovascular system, because our muscles, we have muscles around our blood vessels, but also some of our blood vessels are near other muscles. Okay, so let's look at the characteristics of the different types of blood vessels. So I'm going to point you over to the far right side right away. So the purple bar graph is the thickness of the endothelium layer. The blue is the amount of elastic tissue, red is smooth muscle, and then this yellow is the fibrous tissue. So arteries have all of it, but they have a lot of smooth muscle. They have a lot of elastic tissue, and they have a good amount of fibrous tissue too. So we see a mixture of them. They're on average about 1 millimeter thick, the wall, and then the diameter, so the distance in the lumen, the hole, it depends on which type of artery we're looking at. There's quite a range. I mean, the aorta is significantly bigger than other arteries. Let's move now to the arterioles, and again over to the right side. There's no elastic tissue in the arterial. There's no fibrous tissue, but there is a lot of smooth muscle. And then we've got our endothelial layer, which is about the same all the way through. So the arterial, again, this ending is an indicator that there is smooth muscle wrapped around it. Arterioles function in vasoconstriction or vasodilation. And those signals come from either hormones or from the autonomic nervous system. Our capillaries are the thinnest in the thickness of the wall, and also in the diameter. We're in micrometers here. Notice artery is in millimeter. They have only endothelial tissue. There's no elastic or fibrous tissue. There's no smooth muscle around them. And that speaks to the job. That speaks to the function of the capillaries, which is to exchange materials, exchange nutrients, the movement of red blood cells to carry those respiratory gases. So if there were thicker layers around them or muscle around them, it would shield the ability to do the job. Next, we come to the venules, and they have a lot of fibrous tissue in them, but not anything else. And then our veins have, like the arteries, they have all 4 components present. So now think about the general jobs of each of these. The arteries are a pressure reservoir, where the veins are a blood or fluid reservoir. So, so that speaks, the arteries, pressure reservoir, that's why we see the elasticity present here. But 2, when we change blood volume, that can have a big impact on the dynamics, the local dynamics present in the veins. So there is elastic tissue present in both the arteries as well as in the veins. Okay. Oh, I'm so sorry. I went past, I don't know why I did that. So looking at table 15.1 from your textbook, just a reminder that blood flow is equal to the change in pressure divided by those resistive forces. Let's talk about some of these different factors. So you know that blood is only going to move if there is a pressure gradient. We learned about that in chapter 14. And it's going to follow just like any gradient. It's going to go from higher pressure to lower. Same is true with diffusion of a gas. It is opposed by resistance, right? Resistance is in the denominator. 3 big factors that affect resistance are the radius of the blood vessel, how long it is, but then also how thick the blood is. The units for flow, we typically use milliliters per minute. Velocity, which is a rate, so time is always in the denominator. We usually express as millimeters per second or centimeters per minute. And then for velocity, which is when we hold that flow rate constant, it's really that cross-sectional area that is what determines velocity. So how wide it is or how small it is. Okay, so let's look at our arteries and begin to understand how they function as a pressure reservoir. So the left side is when we're in ventricular contraction. Okay, so here's the ventricle. So we're just looking at a very simplistic view here, just the ventricle. This would be the semiluminar valve opening into the aorta and then out to the aorta and the rest of the arteries. So in ventricular contraction, right, the ventricle is smaller, shown in from the dotted line at what it would be at relaxation. When the ventricle contracts, that pushes open the semiluminar valve, allowing the ejection of the blood that is in the ventricle to move into the arterial side. That swells, that pressure expands the elastic components of the arteries, and we see the blood vessels increase in diameter. So they're able to accommodate for changes in pressure by stretching or going back to their normal size. On the other side of the figure here is the ventricle when it is in the relaxed state. So this would be when the heart, the cardiac cycle, is in isovolemic ventricular relaxation. There's no change in the volume of the ventricle because there's nothing to push it. There's no contraction. We haven't gotten there yet. So now we're seeing that the semiluminar valve is closed. So there's no increased pressure to expand the arteries. So we're looking at the elastic recoil here. Elastic recoil. I keep tying this word elastic, not with the stretch, but with the return to normal shape, because that's what elasticity is. So our arteries are a pressure reservoir. And just like we've seen so many other times in biology, the structure meets the function. So the different components of the wall and what's beyond it of the arteries allow it to function this way. Now we're looking at something called mean arterial pressure. So that's the blood pressure in the arteries. But 2/3 of the blood is in the veins at any given time. So we're really, let's look at what this concept of mean arterial pressure is. So what it is it's the diastolic pressure. So that's at contraction, relaxation, plus 1/3 of the pulse pressure. So 1/3 comes from the fact that only 1/3 of the blood is in the arteries. That's where that comes from. All pulse pressure is it's the difference between our systolic and our diastolic pressure. That's what pulse pressure is. So now let's apply it to the pathway through the cardiovascular system. So imagine we're a drop of blood coming out of the left ventricle through the arteries, through the arterioles, capillaries, venules, veins, and finally back up to the right atrium. Oh my goodness, the Zoom translator is going to have fun with that. I just blurred it all together. So look at the pressure. The pressure is what's on the y-axis here. There's so much variation right in the ventricle, in that left ventricle, because it changes in response to what's happening in the ventricle contracting. But as the blood leaves the left ventricle, right away, there is less variation. And that has to do with the fact that the blood is now out of the ventricle, past the contraction, and within a blood vessel that is made out of different materials than the heart is. So we have a decrease. The oscillations are not as grand, but there's a gradual decrease in the pressure as the blood moves through the arterial side into the capillaries. And then essentially, I mean, really by the time we're looking in the capillaries, the blood pressure is negligible. I mean, there's a little bit, but there's not much. But look, it continues to decrease as we go through the venules to the veins. Well, how on earth does it make it back up here then? Because our heart's up here. So how does the blood get back up to the heart when there's not pressure pushing it? So the pressure pushes it through the arterial side, the heart pressure, the contraction, but that's not true of the venous side of it. So we do have other mechanisms to deal with that. So this kind of lighter peach line, that is the mean arterial pressure, and it's representing the pressure of the blood that is in the arteries, which is pretty close, really, to the pressure that's in the venous side, because there's not much there. But keep in mind that 2/3 of the blood is here. So that does affect it. If there were less blood, it wouldn't have as much of an impact. So our systemic circulation pressures do change as the blood moves through the different blood vessels. So we see that it's high in the arterial side, but then pretty much nothing after we get through the capillaries. So we're seeing a decline in pressure, but also in the amplitude, in the wave, in the effects of the heart pumping. So go through this on your own time. Just practice figuring out this simple math. So what is the systolic pressure? What's the diastolic? What's the pulse pressure? And then you can plug it in to this formula here to figure out what the mean arterial pressure is. Here's another way to figure it out. So if we want to do it on a person, I mean, really, you would have to stick a probe in their arteries. That's invasive. That's not going to get done just for our normal follow-up. But we can estimate it through our different equations here. So it is equal to the cardiac output times the resistive factors that are present in the arteries. And again, it's in the arteries because we're talking about arterial pressure. So that is the diastolic pressure plus, brackets here, pulse pressure divided by 3. So it is balanced though. It is necessary. It helps to balance the flow of blood as it moves through the arterial side and change as it changes the type of blood vessel. That's what I'm trying to say. So the inflow is all about the left ventricle because that's where that contractive pressure comes from. The outflow, though, is going to be diminished by any resistance in the periphery outside of the heart. Specifically, that would be coming from the arterial, since they're the ones that can clamp down. They have the muscles to do that. So the blood flow into the aorta is equal to the output of the left ventricle, providing everything's healthy. So when we see that there are changes in blood volume, it does affect pressure. So if we have an increase in blood volume, that's a way to increase blood pressure. So a person that's being treated for shock, which is associated with low blood pressure, one of the necessary standard treatments for shock is to get usually 2 IVs in a person to run fluids in as quick as possible, because by increasing the blood volume, it increases the blood pressure. And what people die from when they go into shock, it's the low blood pressure. If our blood volume is decreasing, that's going to decrease pressure. So if a person suffers a type of internal bleeding, for example, that can decrease their blood pressure. So let's look at these 2 different equations to both calculate the same thing, mean arterial pressure. So it is the pulse pressure divided by 3 plus the diastolic pressure. Pulse pressure is systolic pressure minus diastolic pressure. And it's 1/3 because only 1/3 of the blood is in the arteries. It is also the same thing. It's approximated by the cardiac output times any resistive factors. So now let's apply it to this picture. So here's our left ventricle, which is equal to the cardiac output. The volume coming out of the left ventricle is equal to cardiac output, which moves through the aortic semiluminar valve, expanding the elastic component of the arteries. But once the blood moves into the arterioles, this is where we get the resistive force. It's not in the arteries, it is in the arterioles. Resistance is applied in the arterioles by clamping down, by contracting the smooth muscle. Look how thick this layer is compared to what it is here. That's what the gray layer represents, is the smooth muscle that is around the arteriole. So the mean arterial pressure is equal to what comes out of the ventricle, the cardiac output, times whatever resistive factors that really impede it or slow it down. Another way of looking at this is that mean arterial pressure is determined by blood volume. If blood volume increases, that increases arterial pressure. So fluid intake versus fluid loss, that ties in our kidneys. We'll learn about that at the end of the semester. Our kidneys are so important in regulating our water balance. Mean arterial pressure is also determined by the cardiac output, how effective the heart is. And cardiac output is the product of heart rate times stroke volume. Stroke volume is what comes out of the ventricle during one cycle. Mean arterial pressure is also determined by the resistance, and that comes from the clamping down of the smooth muscle that is around the arterioles. It's also affected by the distribution of blood. How much of it is where? Is 1/3 of it in the arteries and 2/3 of it in the veins, or has it been redistributed? So the diameter of the veins is a big part of that. So now let's talk about the control mechanisms that regulate this so that we can really understand the different components that do affect mean arterial pressure. So what we're talking about, the integrating center here, is the cardiovascular control system, which is in the brain. So we're looking at blood pressure control here. With an increase in blood volume, more cardiac output will increase pressure. What does that do? Well, it triggers two different responses at the same time in the integrating center of the cardiac control center. We have a fast response. We also have a slow response. The fast response is going to be either dilating the blood vessels, vasodilation, and or decreasing cardiac output. That quickly can get our blood pressure back to normal. If we dilate the blood vessels, then okay, then that's a way to deal with an increased pressure. The slower response comes from the action of the kidneys, and this involves some hormones, which is why it's slower. But that response is going to be to excrete water in the form of urine, which would lower the blood volume, but that takes a bit of time. So this is good. We have a quick response and a slow response to deal with regulating blood pressure. So this is in response to increased pressure. Now, our body's really good at regulating this, though. We don't usually see big changes in our mean arterial pressure because it can deal with the oscillations. Remember that figure we looked at when we were defining mean arterial pressure. Now, the veins work as a blood reservoir, and they're capable of changing the blood flow throughout the rest of the cardiovascular system. Let's talk a little bit more about some of the anatomy and other features of the veins. So as the blood flows through the arterioles, through the capillaries, and back into the venous circulation, eventually back to the heart. I mean, look at your body. Where's your heart? It's up here. I mean, the majority of our body is below the gravity effects that would benefit getting the blood up. So our blood has to go against gravity too. It does this with the action of really two things. There are valves that are present in our venous circulation that keep the blood flowing one way. So they close and open and close in a way that pushes the blood up. But then there's also a muscle pump, and that's what we're seeing here. So let's run through it. So we can see now, looking at the left side of the back of this person's leg, the calf, the valves are closed. The valve's closed here. And we have another valve down here. So the valve's open to allow the blood to go in. Then we get squeezing of the skeletal muscles. The calf muscles are squeezing, which reduces the diameter of this vein, which then increases the pressure enough to open the valve so that the blood can flow up to the next segment. So these are the two adaptations that are present in the venous system that allow the blood to get back to the heart, even though there's hardly any pressure to drive it. Okay, let's look at the example of hyperemia. And this is normal. So after you come off of the field or I went to ballet this morning and certainly was huffing and puffing at the end of it. Our body is breathing faster, our heart rate is faster as a way to meet the metabolic demands. That way we get, we breathe heavier and faster to get more oxygen in to hopefully compensate from any lactic acid buildup, as well as just to get good oxygen delivery. So hyperemia is tied to the blood flow, which is tied to metabolism. So when we have a higher rate of metabolism, there are going to be vasodilators, chemical dilators that are released into the extracellular fluid, causing the arterioles to dilate. And that is going to decrease resistance, because if we dilate, that is going to decrease resistance. If we constrict, that's applying resistance. So if we decrease resistance, that will increase blood flow eventually. And that gets more oxygens and that gets more oxygen and nutrient right there to where it needs to go. That's different from reactive hyperemia. So what we've been talking about is active hyperemia. Reactive is when, say you're sitting down and you've got your legs crossed and you've cut off the blood circulation in the bottom leg. That's what reactive hyperemia is. And you've all felt what happens, right? If we sit there long enough, we'll get up and your arm or leg feels asleep for a bit of time until the blood flow recirculates. So now we've got some type of occlusion that causes it, but that builds up these vasodilators that are just being produced from metabolism. And that causes the arterioles to dilate, but the occlusion's in there and that prevents blood flow. So the fix is to remove the occlusion. Maybe there's enough pressure to push it out naturally, or maybe it takes going into the angioplasty suite and having it, pushed open through a surgery. But that would decrease the resistance and allow blood to flow. And eventually all those vasodilators are going to dilute out and wash away, and we go back to normal. So that's hyperemia. We have active and reactive. Now that smooth muscle that exists around the arterioles is under sympathetic control. So you know about that. That's true of pretty much every smooth muscle, with the exception of the erectile tissue. You know how that's stimulated. I'm not going to go into that. So that would be an extrinsic control of resistance in the arteries by changing the sympathetic signals that affect the smooth muscle that's in the arterioles. We'll talk about these alpha receptors. So we have sympathetic control of our smooth muscle, but we also have signals coming from the nervous system and the endocrine system through hormones. So the two molecules we're really talking about now are going to be epinephrine and norepinephrine. We've got some others too. We've got these atrial natriuretic peptides, AMPs. There's a whole group of them. And then there's also a very important molecule called angiotensin II. This is a hormone. So we've got a number of ways to control our resistance, and that makes sense. The more important a parameter is in our body, the more pathways there are to help regulate it. Okay, so let's look at just resistance and flow with this molecule norepinephrine. So first of all, we'll run through the normal pathway. So we have a neuron that's sending its signal the norepinephrine acetyl neurotransmitter is released, binding to the alpha receptor. And this is happening at a normal, moderate rate of signal. But what happens when there is a change in the signal? So we're talking about tonic control. Again, anytime we're talking about tonic control, this is that minimum amount of contraction that is necessary to keep our body firing. So these responses are always active. The way that our body perceives a change is if the frequency changes. So if we have more epinephrine being released and binding to the alpha receptor, we're going to get constriction. Okay. If we have less norepinephrine being released, where it's not binding onto the alpha receptors, then we get dilation. So the action of norepinephrine binding the alpha receptor is constriction, but it's dose dependent, if you will. It's based on the amount of norepinephrine that's present, as well as the frequency. All right, I wanted to make this table because, so you have something clear. These are the three main types of the adrenergic receptors. So we have the alpha receptor, a beta 1, and a beta 2. So they're located at different parts in the body, and they're sensitive to different molecules. So when norepinephrine binds the alpha receptor, it causes constriction in the smooth muscle. That's what we just saw. When norepinephrine binds it, it causes constriction. But both norepinephrine and epinephrine combine the beta 1 receptor. That's present on the myocardium cells, both the pacers as well as the contractile cells. So that means we can affect the heart rate. We can affect the contraction force by binding of these molecules. So that would enhance the heart rate by more rapid depolarization, or a more increased rate of depolarization. When the beta 2 receptors are bound by epinephrine, and these are present in the arterioles of the heart, but they're also present in smooth muscle, now we get dilation. Dilation of the arterioles, but also dilation in the lungs. So those are the effects of the neurotransmitters binding to these three different types of receptors. Keep in mind, though, that when this type of response is happening, when we're talking about the molecules epinephrine and norepinephrine, the response is happening over the whole body at the same time. It's a coordinated response. So let me just back up for a minute. So the example that I like to think about and use here is the fight and flight response. And I think I've mentioned this in lecture before, but pretend you're a rabbit. Humans are terrible examples at natural selection because we don't do it. We do artificial, we do human selection. But if we're a rabbit and our fight and flight response gets kicked off, it's probably because there's a predator chasing us. So a predator chases us and we're a rabbit and we're like, oh my gosh, we need to run away. We're not going to sit there and nibble on grass. The rabbit's not going to stop and eat. We're not going to stop and eat a sandwich. We do not need blood going into our GI system because there's no reason to process it there. So that part of our body, the vessels constrict because we don't want the blood going there. It shunts the blood to where it needs to go to deal with the fight and flight response. So it sends it into the skeletal muscles so the rabbit can run, and it sends it into the brain and other major vital organs so that the senses are heightened. What happens during fight and flight is all those senses are better. We can see better, we hear better, we can smell better, and we can respond by running away. So again, that's what's happening with these molecules. So I use that example because that's a good example of when both of these are released. What I sometimes have seen happen is people don't understand that this is happening all at one time in a continuum. So it makes sense that binding of the same molecules to different receptors that are present on different parts of the body would have a different response. That's really what it is. So the difference between epinephrine and norepinephrine, I want you to think about this and kind of go through it. Now, if you go and look at the note view of the slide, I've put the answers in there for you. So that way you can double check yourself, but try to do this without looking at the answers. These are some questions from your textbook. So this is the concept check 8 and 9 questions out of chapter 15. So I encourage you to do the same thing. These answers are available in your textbook. Okay, so now let's go through, continue our discussion of the regulation. So we've got our cardiovascular control center, which sits in our brain. This is new. It ties to what is called the baroreceptor reflex, and this is for blood pressure regulation. We haven't talked about baroreceptors yet, but we have talked about something very similar. We talked about proprioceptors in skeletal muscle, those sensors. Baroreceptors are very similar. They're sensors for blood pressure. They're always firing. They're always on. What leads to a response is either an increase in the frequency or a decrease in the frequency. So our baroreceptors, we have a few kinds. They're present in the carotid arteries and in the aorta. So in the coronary vessels and or the carotid arteries, as well as in the aorta, right by the heart. So they're sensing the pressure right by the heart. And it's a change in frequency. So let's talk about changes in blood pressure as they trigger this baroreceptor response. So hypotension, too low, and then orthostatic. This is a type of blood pressure that, okay, let me back up. So when we change positions from laying down or sitting to standing, if our baroreceptor response functions properly, we don't get dizzy. We don't have a drop in blood pressure. But sometimes that can happen. And that is what is called orthostatic hypertension, hypotension. And it's more common in the elderly. Part of the reason why is protein synthesis is so much lower in the elderly. You know, they're not making all the muscles and other that's a lot of protein. So that affects all of the osmosis and water distribution in the body. Try to think through that on your own time. So so that's one way to where we see it. We see it a lot in the elderly. But what would be the outcome? I mean, yeah, you don't want to fall and hit your head. That's bad. But actually, if you fall down flat, that triggers another baroreceptor response. And if you're laying down flat for about 10 seconds, then it can help to correct itself. So as long as you don't hit your head. Okay, let's go through that. So we're beginning in the medulla oblongata. That's the region of the brain where the cardiovascular control center is. We are going to begin with a change in blood pressure, which is sensed by the carotid and the aortic baroreceptors that are always on. So we have a change that is sent to the integrating center in the brain, and then out comes, we've got either a parasympathetic or a sympathetic pathway. Hopefully that makes sense to you at this point. If we're triggering the parasympathetic pathway, that is going to slow down firing of the SA node, slowing the electrical conduction of the heart, which will reduce the cardiac output, which will reduce the heart rate. But if we are triggering the sympathetic pathway, we are increasing firing of the SA node too, but we're also increasing the contractibility of the ventricles, the vasoconstriction of the arterioles and the veins, all as a way to get the blood back up to the heart faster and quicker in increasing cardiac output. All right, so now let's go through the reflex a little bit more. It's basically the same thing we just looked at, but we're gonna next look at a decrease in pressure. So what I would like you to know with this baroreceptor response is which neurotransmitters are associated, which receptor it's binding, and then what the effect is. Where's that receptor located and what is the effect? So with an increase in blood pressure, the baroreceptors and the carotid and aorta are going to be firing faster. That is going to increase the afferent pathway of signaling through an increased frequency into the cardiovascular control center that is located in the medulla oblongata of the brain. If we have, so we're in response to high pressure. So we want to decrease the sympathetic response and increase parasympathetic response. The sympathetic neurotransmitter is norepinephrine. We learned this in chapter 14. The parasympathetic neurotransmitter is acetylcholine. So if we're decreasing the sympathetic output, that means less norepinephrine is going to be released, which would bind to the alpha receptor, causing vasodilation. Norepinephrine also targets the beta-1 receptor, which is present on the myocardial cells themselves. And this is how the ventricle becomes either more contractible or less contractible. So in this case, in response to the high pressure, it's going to become less contractible, goodness, you know what I'm saying. And that will decrease cardiac output, decreasing blood pressure. To increase the parasympathetic output, that would be more firing of the acetylcholine, which binds to the beta-1 receptor, which is present right there in the SA node. And that will slow heart rate, which decreases cardiac output. This response, the baroreceptor response to correct high blood pressure, is under a negative feedback loop, where when we get down to the healthy blood pressure, it sends it back off to turn off because we get back to the right firing frequency, and therefore we're back at normal. So this is the response to high pressure. The response to low pressure, again, know the same things. Now we have less firing, less frequency being integrated into the cardiovascular control center. So now we want to increase sympathetic output. So we want more norepinephrine, we want less acetylcholine. And I think you can put together the rest of the pathway. So please be able to go through these pathways, but also apply a clinical situation. Like if I tell you that a patient was brought in to the emergency room and their blood pressure is low, they don't know why, what would be a corrective response to fix it? Something like that. So some of the terms to really focus on for chapter 15: hypotension, including orthostatic hypertension, hypertension. We've got transient hypotension, which is different from orthostatic hypotension, and shock. The reason people die of shock is because of too low of a blood pressure. Hypovolemic shock is due to too little blood volume. So an internal bleed or an external bleed could cause hypovolemic shock, where we're losing our fluid quickly. Let me back up a minute. So one of the treatments for any type of shock is to administer epinephrine. Let's go back. That would be a response to if we have too low of a blood pressure and we're administering epinephrine, it's going to trigger this pathway. It's going to cause vasoconstriction, which will increase the blood pressure. So epinephrine and wide open fluids are our standard treatment for shock. Okay, so what we haven't really focused on yet is what's happening in the capillaries. We know that they're the sites of exchange, but there's more happening here. Our body is able to compensate for pressure changes some by regulating blood flow across the capillary beds. So what we're looking at is an arterial, and a venule, and then the inside intermeeting capillaries. There are valves that are present, or sphincters that are present at different places within this capillary bed. So in the bottom panel, the pre-capillary sphincters are constricted in 3 places, and that pushes blood through what is now called a meta-arterial, because it's shunting all of the blood from this capillary bed into the single vessel, which is going to still come out the other side. So let's apply why this is important. Look at the top example. We've got 4 even size blood vessels coming off of a common one. So imagine we're going into a capillary bed, and it's going in at 4 liters per minute. Our blood flow is 4 liters per minute. And since our vessels are all equal and there's no difference in resistance, it will flow evenly through each. So each gets a fourth at 1 liter per minute. But what happens here if blood vessel B constricts down or closes its sphincter, and it's only allowing a quarter of its blood flow through? Well, that means the rest of the capillary bed takes the 3/4 evenly, because they're the same size. And we learned in the beginning of chapter 14, when we were looking at the tubes that stuck up and looking at the flow of water going through, that if we have the same architecture, the same anatomy, the distribution is going to even out. So the cross-sectional anatomy is important in determining the distribution of the blood through capillary beds. So this is one way that the body can even deal with injury. I mean, we have capillary beds everywhere. I mean, why don't we just bleed like crazy from capillary beds? Or anytime we get a paper cut? 1, we have a blood clotting system, but also 2, we have the ability to reduce blood flow under different triggers. So the capillary flow, the blood as it's coming out of the capillary beds and goes into the venules, into the venous side, it's like a lake going into a river. So this is a figure that Dr. Tomford uses, and I like it because it's showing us that even though we've got so many capillary beds, which we do, there's far more capillary beds out of any vessel that we have. The majority of our blood vessels are capillary beds. It still opens up into this big vastness. And if our body didn't have the valves and the skeletal muscle pumps to push the blood back up, it wouldn't get there, because it's going into a bigger vessels, which is going to decrease pressure even more. So that's why the capillaries have a higher pressure than do the venous side. So oh my gosh, I'm sorry. I keep hitting my mouse weird today. So let's look at that. So we're looking at the velocity of blood flow as it moves through the different blood vessels. So it starts pretty good and then it drops off, but it does pick back up. So how do we increase the velocity? Well, it has to do with the cross-sectional anatomy as well as the skeletal muscle pumps and valves. But look here, this is a graph showing the cross-sectional area of each of the blood type vessels. By far, we have the majority are capillaries, then venules, then veins. So we have way more venous side than we do arterial side. So it makes it, and as you can see nicely from this graph, the cross-sectional anatomy and the velocity are inverse, where one is low, the other is high. We do have different types of capillaries. We have continuous capillaries. We have these fenestrated capillaries. These ones have big pores. Continuous capillaries, though, are leaky around the junctions. So right around here, there's the ability, right? So you could see that solids could go all the way through. We also have vesicles that move materials through. You've got the basement membrane that you have to get past, right? That's what this gray or purpley area is. So transcytosis is the process of materials just moving across the endothelium. So we can do that in vesicles. There are channels, just different material moves in different ways. The fenestrated capillaries, though, they have the pores. So this is an example over here. What we're not seeing yet, you can see all the pores. What we're not seeing yet is that our body has a way of regulating the passage of fluid through those pores. Okay, so how does exchange actually happen at the capillary bed? We have three main ways that material and fluid is exchanged there. So we have by bulk transport, diffusion, so that would only work with material that can diffuse, providing there's a gradient, right? And that all ties to the vessels too. And then we have transitosis, which we were just looking at. So bulk flow is pressure dynamic in a closed system. So things are going to flow because they've got the closed system of the cardiovascular system and the heart pumping it. That's an application of how to think of bulk flow. So we've got a number of different ways to move material, which is good because that's the whole purpose of the capillary bed. We have more than one way to get material across it, since that is the job of the capillary bed. So every day, on average, 3 liters of fluid goes through the capillaries. 3 liters of fluid a day goes through the capillaries. And so much water is released, as you can imagine. So our blood the pressure pushes the fluid through the arterial, and now we're going through a capillary bed over to the venules. What we haven't really talked about is the role of the lymph vessels here, these green vessels. These are so important in recovering that bulk flow fluid to get it back into the heart. The lymph vessels are going to connect with the vena cava to dump this fluid back into the right heart so that it can be added with our blood volume. If we did not have the lymph vessels that are picking up all this fluid that does leak into the extracellular environment, we would not have a way to keep our blood volume constant. So the lymph vessels are important in our immune reactions, yes, but they're very important in recovering the fluid that leaks out of our capillary beds into the interstitial fluid. So as we move through our capillary bed from the arterial side to the fluid side, so our net flow again is about 3 liters per day. Let's look at our different pressures. So we've got 2 types of pressures at action here. We have our hydrostatic pressure, which is shown in the blue. And this is changing. Look, it's higher close to the arteries. It's changing. But the colloidal pressure isn't. The colloidal pressure is the pressure that happens when different particles hit into each other. So it's a type of osmotic pressure. And as we move through, you can see that our hydrostatic pressure, which comes from the pumping of the heart, decreases. So think of 3 causes of edema, which is the buildup of fluid, particularly in the lower extremities. This is a hint for you to think about. You've got an exam coming up. So what are some of the factors for cardiovascular disease? Well, you know these. There are many that we can control, but we can't control things like our family history, our age, or our sex. But things like smoking and obesity, diet, not treating high blood pressure, that's also something that can be controlled. There's genetic factors too, but some of these can be modified by lifestyle. So for example, type 2 diabetes is a disease of the metabolism, but it's associated with the development of atherosclerosis, which leads to cardiovascular disease. So if we can control the type 2 diabetes, that is a way to hopefully prevent cardiovascular disease. As I was talking about in the last lecture, atherosclerosis is also an inflammatory process. which means that anti-inflammatory treatment holds promise. So it's associated with too much cholesterol, and cholesterol lives right in the phospholipid bilayer. It's also associated with too high of the triglycerides. So we have too little of the healthy cholesterol, the HDL, and too much of the unhealthy LDL. HDL is healthy. Also, we have these other factors, and we're going to learn, we'll continue this discussion throughout the rest of the semester too. We have this ApoB molecule that will combine with LDL receptors, and that accelerates the inflammatory process. So let's talk about how these plaques develop, leading to atherosclerosis. So this is a picture of the arterial wall, and this is normal physiology. So on the very inside, we have our endothelial layer, then we've got our elastic components, and then we've got our smooth muscle that wraps around it. And as cholesterol, which is this yellow, LDL cholesterol builds up, it's building up in between the endothelial layer and then that connective tissue. That is going to cause macrophages, which are part of the immune system. Well, their job is to eat things. That's what they do. I mean, they're phagocytic cells. So they're going to try to ingest the cholesterol, and they become what we call foamy macrophages. That's this big cell here. Our cells of the smooth muscle now are starting to become disrupted, right? Because of all this inflammation building up. And they're going to divide and also try to take up the cholesterol. So at this point, we've got a stable fibrous plaque. You can see the fibrous layer around it. So it's got fat inside, but then we've got this fibrous material around it. We've still got macrophages. We've still got our muscle cells. This white cell here is a calcification, which will build up over time. Now, down in the bottom panel, we're looking at a vulnerable plaque, which could rupture. And we don't have an intact fibrous layer anymore. The macrophages too, these are really potent cells, and they release a lot of chemical signals into the environment that are going to have an impact on collagen. And the plaque becomes unstable at this point. We also have platelets, these little cells at the top. These are platelets. And platelets become activated when they are exposed to collagen, which is what's happening as the plaque bursts open. That will lead to the formation of a blood clot. So really, hypertension, if a person has hypertension, the body's not correcting. It's not getting back to homeostasis. It hasn't fixed it through the different baroreceptor control mechanisms. So our risk of developing cardiovascular disease does double every time we increase the systolic by 20 and the diastolic by 10. And that's over a baseline value of 115/75. Think about that though. Many healthcare providers use 120/80 as the healthy cutoff, but cardiologists don't. And I'll show you a graph that shows why. So, I mean, that might be a discussion to have with a primary care physician, or if you go into primary care, to think about that. There's a difference between 120/80 and 115/75. It was lowered several years back. So primary hypertension is about 90% of the cases, and there's no clear cause other than heredity. In primary hypertension, the cardiac output is usually normal, but there's resistance. So buildup of plaque and things like that could happen. We've got separate secondary hypertension, which is happening in the other 10%, and that's due to some underlying pathology or some other chronic illness. Both of these, regardless of the type, blood pressure is a risk for atherosclerosis, and it's something that we want to treat immediately. By the time that we're seeing changes on the EKG, there's already been damage. So treating blood pressure, we want to treat it before it leads to changes on the EKG, before that heart damage has already occurred. In conditions like pulmonary edema and congestive heart failure, the muscle actually goes into a hypertrophy where it becomes big, but it's just not functional. The muscle's not working the same way. So how do we treat hypertension? There's actually a number of different mechanisms, different medications. And this might mean using different types of medication in the same patient because 90% is primary. We don't know what causes it other than hereditary. And there's different factors that can cause it. So by taking a calcium channel blocker versus a beta blocker, the beta receptor, those are different pathways, right? Different mechanisms in blood pressure. So it often does make sense to try different medications out to see if one or more work better. But the important thing is to do it quickly prior to causing any heart damage that shows up on the electrocardiogram. So this is an electrocardiogram. It's a 12 lead, kind of all sandwiched together. But it's of a patient that has hypertension. Do any of these look like the normal heart rate? This one kind of does. No, 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 we got a big negative here before the T. No, 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 no. Oh, wow, we've got inversion now. No, no, no. So there can be very profound effects on the cardiovascular disease system from high blood pressure, but we can treat high blood pressure. So here's the graph I was referring to a moment ago when we were talking about the difference in what is a healthy blood pressure. So as we increase by 20 in systolic and 10 in diastolic, we are doubling our risk of cardiovascular disease quite quickly. So a lot of people aren't even being treated for blood pressure until they're here. So they've already got, a 2.5 to 5% relative risk of developing cardiovascular disease. All right, that wraps us up for chapter 15. I really hope this lecture comes back quick. Zoom is giving me all kinds of grief. This is actually the second time I recorded this lecture because I never got back the first one. So hopefully this one comes back soon. Please reach out with any questions. Take care. Have a good day. Have a good night. Bye.